I welcome Dr. Nageshwar Rao sir, Dr. Anita madam, and Dr. Jyotsna madam to
Thank you.
this webinar. Thank you so much, all of you, for helping us to enrich this session. There will be lots of PGs joining, sir. Last time we had close to 100 PGs, and this time we expect many more students to join. Thanks a lot for joining in spite of all your busy schedules. Dr. Anita Madam is a retired professor and HOD of pediatric cardiology from All India Institute of Medical Sciences. Currently, she is serving as the Vice Chancellor of BD Sharma University of Health Sciences at Rohtak at Haryana. Dr. Nageshwar Rao is the Chief of Pediatric Cardiology Services at Rainbow Hospital. He is also the designer of the most widely used device, the Konar MF device, which is used both in Europe, India, and most of the Asia. And he is a great teacher, and I'm sure all of you will benefit from the panelist knowledge. And we have our own dear Jyotsna madam, who is the president of Wincars Association, and she is retired HOD of NIMS. Welcome to all of you. I think maybe in another 2 minutes we can start the session. Today's case presenters are Dr. Nitin and Dr. Gritachi from BD Sharma University of Health Sciences. So the title is Approach to a Case of Cyanotic Congenital Heart Disease. Our two presenters are currently doing DM Adult Cardiology. Welcome to all of you. In maybe in another 2 minutes, I think there'll be few more, and I think we can start the session. Are you ready with your presentation, Nitin?
Yes, ma'am, I'm ready.
Yeah, maybe you can start sharing your screen.
Okay.
Nitin, we would like to see you. Can you just open your camera once?
Yes, sir.
Perfect. So I think Dr. Usha, we can start with the case presentation. Dr. Nitin, the flow would be you will present the case in another 10 minutes, and in the end of the session, for the 5 minutes, we will ask questions pertaining to your history by the panelist, and the next 10 minutes will be your examination part. So you can go ahead with the case presentation, and I would request all the esteemed panelists to do the discussion at the end of the history presentation.
That should be good. Thank you.
Okay. So good evening, respected teachers and my colleagues. Today I'm going to present a case of a 19-year-old female who is a resident of District Jajjar in Haryana. She is educated till 11th grade, and the history has been given by the patient herself and her mother, so it is reliable. The patient presented to PGIMS with the chief complaints of progressively increasing breathlessness since last 2 years, and 3 episodes of blood in sputum in one single day around 1 year back. Although the chief complaints date back to only 2 years, but since the past history has been from the early childhood, so I am starting the history of present illness from the time of first noticing of symptoms. According to the history given by the mother, at the age of around 6 to 8 weeks, patients started developing episodes of tachypnea, chest retractions, fatigue, and sweating overhead during the time of breastfeeding, and she had to take rest for 5 to 10 minutes of sucking, and then resume sucking after some time. However, there was no history of recurrent respiratory tract infections or cyanotic spells during infancy. The patient used to get breathless and appeared fatigued on small amount of activity like crawling, etc. There was history of poor weight gain during infancy, but there was no history of delayed mental or social milestones. There was no history of sweating episodes anytime during her childhood. These symptoms improved at around age of 1.5 years, and thereafter she appeared normal to her parents. She was average in her studies, remained low weight, but continued to normal height over time. However, the patient says that during her school days at around 12 to 14 years of age, she felt fatigue and got breathless while doing ordinary activities like running and climbing to stairs for 2 floors, which is NYHA class 2. After a few months, she also started noticing that her fingers and toes started growing big and looked bluish. She did not consider this alarming enough to consult any medical practitioner. Then, at around 17 to 18 years of age, she started becoming breathless while doing less than ordinary normal activities like walking over 100 meters or climbing 1 floor of stairs. This is NYHA 3. One day, while in the morning going to the toilet, she noticed fresh red blood coming from mouth while having little cup. The blood was bright red in color and was around a tablespoon in quantity. During the same day, she developed 2 more similar episodes of blood in sputum. Following this, she and her parents got alarmed and decided to consult a medical practitioner who sensed that it was a serious disease and referred her to PGIMS Rohtak for further evaluation and management. There is no history of chest pain, syncope, facial weakness or weakness in any limbs, headaches or blurring of vision. There is no history of seizures or bleeding from any other side. There is no past history of tuberculosis. On personal history, patient is a vegetarian and has normal sleep pattern and normal bowel and bladder habits. The family belongs to lower socioeconomic class. She was born out of non-consanguineous marriage. Both father and mother are healthy. She is the eldest of the 3 siblings. Younger siblings are males aged 16 years and 14 years, and both are healthy. Perinatal history, there is no history of fetal loss in the mother. The mother gave history of fever without any rash for a few days during first trimester, but did not consult any doctor nor take any medications, and the fever subsided on its own. She was born full-term vaginal delivery at home and cried normally. She has been immunized as per vaccination schedule and attained menarche at age of 15 years of age and has regular and normal periods. So this is the end of my history.
Nitin, can you just summarize your history?
Okay. So in summary, we have a 19-year-old female patient with history suggestive of heart failure symptoms during infancy, with improvement of symptoms at around 1.5 years of age. The child remained asymptomatic for a few years, after which there was again progressive deterioration in the form of fatigue, cyanosis, and clubbing during adolescence, with dyspnea and hemoptysis being the presenting complaints at 18 years of age.
Okay. So why do you say that there is history of heart failure during infancy?
So, although the presenting complaint has been hemoptysis and breathlessness at around 17 to 18 years of age, but on taking a history of past illness, the mother of the child is saying that at around 6 to 8 weeks, she started noticing that while breastfeeding, the child developed suck rest suck cycle, and also during that time she also noted the child used to get fatigued and there was chest retractions and breathlessness episodes. So these probably point towards heart failure symptoms.
Was there any history of failure to thrive also?
Well, there is a history of poor weight gain.
Poor weight.
Although,
Okay.
poor weight gain history is there in infancy.
Okay.
And although there is no history of recurrent chest infections in this child.
Okay. All right. Dr. Rao and Dr. Jyotsna, please go ahead.
Yeah, the history is very interesting. No, there is a history of heart failure, asymptomatic stage, and then becoming symptoms in the form of different symptomatology. So, what is the natural history is suggestive of?
So natural history, this is suggestive of increased QP in the infancy, followed by a period of asymptomatic, apparently asymptomatic period, and then followed by development of pH, probably leading to these symptoms like breathlessness and hemoptysis at a later age.
So basically, you can probably pinpoint a particular possibility based on that history. The first possibility that comes to your mind.
So, ma'am, in this scenario, the most likely scenario is that patient is having some post-tricuspid shunt lesions with initial post-tricuspid shunt lesions, which has over the time led to development of pulmonary hypertension and Eisenmengerization, and now the patient has presented as a cyanotic. Basically, now is presenting as the features of pulmonary hypertension.
Yeah. So basically, you are saying that she is, a large shunt. Let's say a large shunt, not just post-tricuspid, but a large shunt, because smaller shunts don't Eisenmengerize. So it has to be a large shunt, and in most probability, which one would you like to opt for of those post-tricuspid shunts?
Seeing this age of presentation, 18 to 19 years, so possibility of VSD and PDA come to my mind at this stage.
Yeah, I mean, those are the post-tricuspid shunts, basically, large VSD or large PDA. Yes, Dr. Rao, please.
The AP window, what about AP window?
Sir, AP window would have presented at a much earlier age, in my view, but that could be also a possibility.
Infancy, no? Infancy much earlier.
Yes.
And the same, if you take AP window, I agree with you. AP window has got much malignant course compared to the ventricular septal defect or PDA. But AP window always should be a differential diagnosis when you are telling.
I think you should keep AP window also as one of the differential diagnoses, although it is much rarer. So if you have to, pick up one of the lesion which produces Eisenmenger, it should be VSD, large VSD. But don't forget AP window in the list. I agree that AP window may not go through this phase of heart failure and then Eisenmengerization. It may be severe PH to begin with, and patient may present earlier than that, but it is definitely one of the differential diagnoses of Eisenmenger syndrome. But yes, statistically, it is much rarer. I agree.
Ma'am, can we have a poll question?
Any other lesion other than the PAH development? Patient had a heart failure and there is improvement of the symptoms and become symptomatic. So one of the reasons is PAH. Any other reason can be possible?
Nitin, I think you should tell us the various possibilities before Rupali, we go to the question, because this should be the end of history. What are the various possibilities that come to your mind? Let me ask you, or if you have a slide, you can show that slide.
So, ma'am, based on the history, my differential, as I've already discussed, that first would be the conditions with initial increased pulmonary blood flow like post-tricuspid shunts with subsequent development of PH leading to Eisenmenger syndrome. Second, I would like to, ma'am, keep the late presentation of a TOF physiology situation.
So you are saying that it started off as a large VSD, and then
as there was a progressive, there could be a progressive, PS leading to cyanosis presenting at a later age.
Any specific name given to this condition?
Gussul phenomena.
Right. Okay. Then you have third possibility is Epstein's anomaly. Any specific reason to keep it so lower down?
Then Epstein anomaly usually will present very early in the neonatal period, normally, before the PVR falls. But here the symptoms have started after 6 to 8 weeks. So probably this, and also, and this is the primary reason that Epstein anomaly doesn't fit in this case, in my view.
Right.
Dr. Nitin, actually what you put to 5 differential diagnosis has got 5 different natural histories. The first one you described very well, that is a symptomatic patient becoming asymptomatic and then developing the cyanosis. Second one, probably you should change the the name late presentation of top physiology. Instead of that, a large VST, whatever you are telling, becoming acquired right ventricular outflow tract obstruction. Maybe you call it as double chambered right ventricle, or ma'am said that guzzlization. These two things may progress to cyanosis. They generally asymptomatic and pink for many years. Epstein's anomaly has got two types of presentations. A neonatal presentation will have cyanosis, heart failure, then asymptomatic. It is a bimodal presentation. Or else directly they can present progressive symptomatology. What about the natural history of the complex Eisenmengers? What you said, single ventricle, DORV, truncus, how the natural history will be in those conditions? Can you please tell us?
Yes. So these complex conditions will usually present as heart failure in very early age, and they will because they also have increased QP physiologies. So they will initially present as cyanosis with increased pulmonary blood flow situation, and they will rapidly progress towards Eisenmenger, and usually their survival is much less at this age. So beyond 1 year, the survival would be very low. So
absolutely correct. So a malignant course of symptomatology will never have a phase of asymptomatic state. A heart failure with mild cyanosis will have a rapid progressive of symptomatology, and they will never get benefit from any kind of thing. So it's a progressive kind of symptomatology which is becoming worse but never gets improvement. That is the physiology of the complex unprotected pulmonary blood flows, which is going into pulmonary vascular disease rather than calling it as Eisenmenger syndrome. Very good.
Also, idiopathic PAs, the last one that you've written, do you seriously want to consider this? Since the history has been from the very beginning. How do you explain the history of heart failure in infancy if you are talking of an acquired, PAH?
Yes, ma'am. So if we keep aside that neonatal, that infancy history, otherwise being a young female, if any female presents with symptoms suggestive of PAH, then probably I thought that there may be some other defect like a pulmonary, just to bring in some differential from the pulmonary point of view. So
I think you'll have to disregard the earlier history. I agree that
yes.
She has never been sort of shown to a physician, so we don't know if she had a disease or not. But at least as per history, you'll have to really disregard that. If that history was not there, yes, I agree. We should consider an acquired pulmonary artery hypertension in a young female. I entirely agree. But yes, you will have to discard that history. Dr. Josna wanted to say something, madam.
No, that's he already pointed it out. Because in the beginning he was talked only about the PAH. I wanted to bring the idea that not only PAH, even PS also causes the improvement of the symptoms, which he already discussed it. Thank you.
Right. Dr. Rupali, if you want
to go to Yes, ma'am. We shall go to the poll now. Monica, can you please put the questions? So each question, we will have 10 seconds for everyone to answer. Please mark one of the answers, followed by 30 seconds of discussion by the panelists. So this is the first question. Everyone, please do involve. The most common cyanotic congenital heart disease in adults is tetralogy fallow, Eisenmenger syndrome, ICE2, total anomalous pulmonary venous connection, and Epstein's anomaly.
I think this ICE2 and ICE3 are
that is
probably by mistake.
Yeah, by mistake. Yes.
Yeah.
So, Monica, can we put the results of the poll? Okay, majority have 77% have answered tetralogy fallow. So that's the right one. But I hand over to the panelists now for the discussion. Ma'am, Anita, ma'am, kindly.
Yeah, so I think the question is a bit tricky because if we are talking of India, then perhaps this is right. But if we are talking of United States, perhaps it is not going to be Eisenmenger because practically every tetralogy gets operated by the age of 19 or 18. That's her age. So, but yes, in India, in adult, if you have a cyanotic adult who's never been intervened, yes, tetralogy will be much more than Eisenmenger syndrome. But I'm sure the pattern is going to change over a period of time because we are also seeing more and more patients getting operated. TAPVC is very unusual, but yes, we do sometimes see it in practice. These patients almost always come as ASD, and the cyanosis is kind of missed because it is very, very minimal, 90%, 89%, like that. So many of them turn out, or some of them turn out to be TAPVC. The X-ray is usually a giveaway because it's a supracardiac TAPVC in most of them. Epstein's anomaly, yes, I think it's a rare condition, but in adult with cyanosis, it must be thought about. And I would agree with the poll result that TOF followed by Eisenmenger followed by Epstein's, and then lastly one of these complex conditions like TAPVC.
Thank you, ma'am. Dr. Nageswara Rao, sir. Any extra
I
comment?
think that is perfectly reasonable. Instead of TOF, maybe VST, PS physiology, some of the mimicking conditions also will come into that group. I think that's a reasonable answer because from all the perspective, top physiology is a correct one. Whatever the question and answer opinion poll is reasonable.
Thank you, sir. Ma'am, Jyotsna ma'am, any further comments?
Same thing, because we kept only 30 seconds for to answer, so we'll go ahead. Otherwise, we don't have the time.
Sure, ma'am.
Right.
Next question, Monica, kindly put the next question. Next question.
It will take me a minute to launch.
Okay, all right.
You can stop sharing that, Monica. Then only it will be.
So I will read the question before it appears on the screen. You can have some time to think it over. Cyanosis is present at birth in the following congenital heart disease. Number 1, tetralogy of fallow. Number 2, transposition of great arteries. Number 3, truncus arteriosus. And number 4, single ventricle. So you can have 30 seconds now to vote.
Just a suggestion to the technical team, while the poll is being polled, it will be preferable not to show it because people are likely to get biased by seeing the result on the screen. So if we can just keep it confidential and show in the end the result, that will be better.
Correct.
I think they're showing to us.
I think the
They're showing
ma'am,
the-
the results will
Okay.
be only for the panelists. The attendees cannot see the result. They can
All
just
right.
see the option which they can click on.
Okay. Okay.
So let's
Then
stop
it is
the
better.
poll.
However, I think at the end they can show. That's
Yeah.
Yes, sir. At the end, we have shown this percentage is only for the panelists which we have joined. It's a different
Okay.
screen.
Can
Okay.
you please show us the poll result? Jyotsna ma'am, would you like
Yeah.
to take the call on this? Yes.
Yeah, the commonest one and the day one, the cyanosis is present in the transposition of the great arteries. I agree with the poll result also. Usually tetralogy of the fallow takes about 2 to 3 weeks later, and most frequently the 6 to 8 weeks, then the cyanosis becomes manifest very much. Truncus arteriosus and single ventricle comes under the admixed physiologies. Even though they have the mild cyanosis, is usually not detected very frequently. Later, subsequently, we are talking about only the VSD, single ventricle with a VSD, without a PS. So that time the cyanosis is not predominant. So it is definitely transfusion of the great arteries, which are the commonest ones, which will present on the day one. Of course, as we know that all other single ventricle physiologies like HLSS, the hypoplastic left heart syndromes, and even severe abstains, pulmonary atresia, and obstructive TAPVCs, and DTGA with an intact IVS. Actually, much more precise if you would have been kept us with an intact IVS, that would have been a much more better answer. So all these can be considered in the first day and the day of at the time of the birth.
But thank you, ma'am. Sir, Nagesh Rao, sir, any other?
Yeah, I would like to comment. Actually, I was expecting answer TJ close to 100%, but many people are actually thinking towards a truncus also. Transposition, whatever the intracardiac anatomy, it can be simple TGA or TGA VST, TGA VST PS will have cyanosis, undoubtedly. It's extremely rare that TGA with very favorable situation in the presence of large VST, large AST, or large AST and large PDA, that's an extremely rare condition. From the examination point of view, whatever TGA form, you have to tell cyanosis. Whereas second, truncus, why did you choose truncus? Whenever truncus is having a desaturation, that's a very dangerous truncus. Those patients are not operable. Truncus is a high flow situation. The QP is more than 2:1 always, unless there is a peripheral pulmonary stenosis, even though the truncus saturations will be almost always more than 85%. So your clinically detectable cyanosis is very, very difficult. It's a mild cyanosis or pulse oximeter will show. Whereas tetralgia fallow is possible only few cases, severe form of tetralgia fallow, where severe infundibulous PS or valvular PS or close to pulmonary atresia group only will produce cyanosis. Otherwise, by and large, you all know classical teaching, after few weeks, then fetal hemoglobin drops, collateral drops, then PDA closes. Otherwise, we don't tell that 4%. Single ventricle based on your physiology, if it is increased QP or severe pulmonary stenosis will present. So your answers should be probably transposition is first, maybe single ventricle second, or severe form of tetralgia fallow third, or truncus is going to be fourth. Ma'am, can please whatever you can.
I was just surprised because only one answer has been asked. So if you have to choose one answer, it has to be TGA. I know there are other causes of cyanosis at birth, and Madam Jyotsna has already enumerated some of them. And pulmonary, but yes, I think if you are asked one choice, then you just have two choices: pulmonary atresia with VST and not tetralogy, and transposition. These are the two conditions that will be presenting with cyanosis on day one, because the question is cyanosis at birth. And no other condition would have a saturation which is discernible cyanosis at birth. And therefore, if you have to choose one, it should be transposition only. Yes, you can rarely get cyanosis at birth in truncus, single ventricle, tetralogy, but those are extremely, extremely rare. The answer should be TGA. In my opinion, there are just two conditions that produce cyanosis at birth. One is TGA, the other is pulmonary atresia, VST. Even if there is a PDA, they are likely to be blue.
Okay, ma'am. Now over to the presenter to present the examination findings.
If your slide is not okay, great. Go ahead.
This whole screen is not going away from my.
We can oppose screen. You just have cross it. We don't see the poll screen. I think we are seeing your screen.
You can close the post.
You just close the poll screen that on the right hand there will be a cross. You just click on that. It's done now? Yeah. You can go ahead.
Yes. So on general examination, the patient was comfortable both sitting and lying down. She looked alert, calm, and cooperative. There were no dysmorphic features. She weighed 42 kilos and height of 165 centimeters. So BMI was 15.4, which is in the underweight category. Pulse was 78 per minute, a regular, normal volume and character with no radial or radiofemoral delay, and equally palpable in all the four limbs. The BP was 110 by 68 millimeter in mercury in the right upper limb, and in the lower limb it was 116 millimeter mercury systolic. Respiration was 18 per minute thoracoabdominal with no retractions, and all chest quadrants moving equally with respiration. There was no pallor, no jaundice. A uniform central cyanosis with saturation of 80% was present. Grade 3 clubbing was noticed in all the limbs. There was no peripheral edema. JVP was not raised and had a normal waveforms. All the limbs, skull and spine appeared normal. Then I'm coming to the CVS precordial examination. I have combined these findings of inspection and palpation. Mild precordial bulge was noted on the left side of the sternum, starting from second intercostal space downward till the fourth intercostal space. There were no scar mark or no prominent veins noted. However, a visible impulse was noted over the left parasternal area. The apical impulse was at the left fifth intercostal space, 1 centimeter inside the mid-clavicular line, and RV type with the continuation as the parasternal lift. A grade 1 left parasternal lift was present. However, no thrill was palpable. But there was a palpable second heart sound at the left second intercostal space. Then on percussion, the right-sided liver dullness was noted in the fifth intercostal space, and left hypochondria was tympanic, suggestive of situs solitus. Left heart border corresponded to apex, and the right border was substernal. A dullness was noted over the left second intercostal space. Coming to auscultation, S1 is normal, S2 a single and loud. Early diastolic murmur, which was best heard at around second to third intercostal space along the left sternal border. It was high-pitched, decrescendo in nature, and beginning with second heart sound and extending little beyond half of the diastolic phase with no changes with the breathing. No ejection systolic murmur was heard. However, a constant ejection click was heard over the left second intercostal space. No S3 or S4 heard. No murmurs heard over the infraclavicular area, axilla, or back. Other systemic examination was normal. No liver and spleen were palpable below costal margin. No free fluid and no neurological deficit was present. So this is the end of the examination.
Okay, this is the end of examination. So shall we go to the diagnosis, Dr. Rao, or you have some questions?
One question. Okay, after diagnosis, we can ask, ma'am. That's
Okay.
fine.
So show us your diagnosis.
So now based on the now history and examination, my probable diagnosis is situs solitus, levocardia, cyanotic congenital heart disease with pulmonary arterial hypertension and PR, most likely VSD with Eisenmenger syndrome. Patient is in sinus rhythm. There are no signs of heart failure or infective endocarditis.
Do you have any differential diagnosis or just one?
Just one, because
why? Supposing I ask you why not PDA? Because you've written Eisenmenger is fine, but only VSD. It could be PDA, it could be AP window. So you don't want to consider any other?
Then I can consider PDA as a second diagnosis, but first would be VSD with Eisenmenger.
And okay, maybe I'll ask you later. Why do you want to make it VSD? Dr. Rao, please go ahead.
Yeah, same question I'm going to ask you.
Okay. So the question is, why not PDA? What is in favor of VSD?
In the S2, because here S2 is single. In PDA, I would have expected a narrow split S2.
Anything else
This
that
is-
might have helped you to make it PDA besides the second heart sound? If it is present, it would
Very
have
obvious.
it would have been the only diagnosis. PDA would have been the only diagnosis then.
Differential cyanosis.
Yes, I mean,
Because in 50% of the cases, we would have seen a differential cyanosis in PDA, but here we have only uniform cyanosis.
But remember, uniform cyanosis is seen in 50% also of PDA.
Yes,
so it
ma'am.
doesn't
That's why.
exclude.
Yes.
But if you find differential cyanosis, then it is very incriminative of PDA.
Yes.
So that is why not ASD severe PH Eisenmenger?
ASD was the presentation would be in the third decade mostly, and then ASD, if they present with Eisenmenger, then usually we will have a cardiomegaly situation, and then also the S2 would be widely split. So that is one thing.
Yeah, wide and fixed in
Wide
ASD
and fixed.
Eisenmenger.
And
So
plus the
second heart sound.
JVP may also be raised in those.
So I think for
What
students,
about,
it is, sorry, Dr. Rao, please go ahead.
What about the palpation? What is the parasternal heave suggestive of?
Yes, sir.
You said grade 1 parasternal heave, which is almost, there is no parasternal heave. Grade 1, I don't consider it is real parasternal heave. What will happen to parasternal heave in VST, pulmonary hypertension, and AST, pulmonary hypertension, and why?
So, sir, in VSD pulmonary hypertension, since the right ventricle is right ventricle is decompressed, so into right ventricle is decompressed, so that's why we are not able to get a heave beyond grade 1. Whereas in ASD, the ventricle septum is intact, so these patients usually may even get suprasystemic RV pressures. So those suprasystemic RV pressures, then the patient may be having associated tricuspid regurgitation, RV failure. So they may be then expected to have a higher grade of parasternal heave.
Very good.
Actually,
what about
in
the presence
ASD,
of RVS3? If there
Yes.
is a S3, RVS3, what does it suggest? Which condition will have more commonly?
RVS3 is suggestive of RV volume overload. So this
Yeah, RV dysfunction and more RV volume will persist in AST.
ASD.
It is not the 100%, but the presence of RVS3 usually favors in the presence of cardiomegaly. If there is no cardiomegaly, as you said, that AST is unlikely, it may be VST or it can be still PDA. But presence of cardiomegaly suggestive of AST.
I think I just wanted to bring home one point for all the students, that for AST to have heave, RV pressure need not be suprasystemic. It can be even subsystemic, because remember, AST has a left parasternal heave even otherwise because of RV volume overload, even if it is an operable patient. Whereas VSD and PDA never have an RV heave, even if they were operable, simply because the RV pressure never goes more than LV pressure, it can always decompress. But in AST PAH, even if the pressure is subsystemic, the right ventricle can fail because you are adding a pressure overload over a volume overload which was already there. Therefore, even subsystemic PA pressures in an ASD can produce significant RV heave and even Eisenmengerization at subsystemic levels also. So ASD is a different ball game altogether. It has different hemodynamics compared to VSD and PDA.
What
Dr.
will happen
Jyotsna,
to pulmonary pulse volume of PDA in the presence of this early diastolic mark? What will happen to the pulse pressure? Suppose there is a PDA and a PR. What's your grade of PR in this case? Is it mild PR, moderate PR, or severe PR?
So the based on the duration of the murmur was grade 2 by 4 intensity and extended little beyond the half of the diastolic period. So I would grade it as moderate, at least a moderate PR.
So suppose there is a PDA with a moderate pulmonary regurgitation. what will happen to the pulse pressure or what will happen to the pulse volume?
What is the pulse volume in PDA? What is the pulse pressure in PDA normally?
Normally, the pulse pressure is pressure is high in PDA,
Right.
but when associated with PR, because then the pulse pressure may actually reduce.
Yeah, once PAH occurs, that peripheral signs of the aortic runoff, you don't feel about it.
Yes.
But once again the PR occurs, what will happen? Is there a reappearance?
I'm not sure.
Yeah, in case of PDA, moderate PDA, large PDA, your pulse volume is high because aortic runoff. Your pulse pressure is high. If they develop pulmonary hypertension, the peripheral runoff signs will disappear. But in the presence of pulmonary regurgitation in PDA, again, the peripheral signs may persist, may be seen. That is the most of the times we observe. Even many
Yes.
books, including Perloff, they describe.
So the pulse pressures is high to begin with, then it becomes normal, and once PR develops, it goes back to high volume pulse. So that could be another way to differentiate VSD from Eisenmenger, or VSD from PD Eisenmenger when you have PR. Your pulse pressure in this patient was pretty normal.
Normal.
Yeah.
Ma'am, there's a question in the question answer box from the audience. So, would you call a Eisenmengerized VSD as a cyanotic heart disease?
So I think that's a good question, but what we generally tell our students is that if somebody is presenting with cyanosis, whatever may be the reason for this cyanosis, whether it is Eisenmenger or tetralogy, it has to be called CCHD. And actually, Eisenmenger syndrome is classified as a cyanotic congenital heart disease with reduced pulmonary blood flow, like tetralogy, but with severe pulmonary artery hypertension. So it is CCHD, there's no doubt about it. Yes, there are some patients who present with a borderline situation where the cyanosis is not clinically obvious and the saturations are more than 90-95%, and these are the patients who are kind of borderline operability. Those patients can still be labeled acyanotic, but once the patient has cyanosis, once the saturations are low, whatever the cause may be, it has to be CCHD.
Okay, yes, ma'am.
I hope Dr. Rao agrees with me.
There is one more question in the box. Usual age of Eisenmenger syndrome in VST and PDA is less than 2 years. So that is the question. The Eisenmenger syndrome by and large will not present less than 2 years. So reasons are the pulmonary hypertension, pulmonary vascular disease, which takes more than 2 years. By the end of the first decade only you will see. However, there are subset of population where neonatal PVR never regress, associated syndromes like Down syndrome, and associated neonatal problems like mechanoaspiration. These are the subsets. They will never get a asymptomatic stage and other things. They directly may get Eisenmenger syndrome. So I may ask ma'am also to clarify that clearly to the students. Am I correct, ma'am?
Yes, I think we are probably talking of two different situations. One is, when does Eisenmenger starts to happen? And you are absolutely right. And I think the person who has written the question is also right, that the Eisenmengerization, or let us say increase in PVR, may start as early as 2 years in a VST, or even earlier in a PDA. It may be earlier in a PDA, maybe 1.5 years. I have seen patients of 18 months of PDA with definite Eisenmenger. We've catheterized and we couldn't operate on them. So the process of high PVR, yes, does happen, or maybe gets established by 2 to 4 years of age, mostly between 2 and 4. However, the clinical cyanosis takes time, and therefore patients, as far as cyanosis is concerned, usually comes up in the late first or early second decade. And therefore, to say that Eisenmenger should present at 2 years may not happen, except in certain special situations. Most of the time, these are the patients who improve because their pulmonary vasculature increases, their pulmonary blood flow reduces, but they've not gone to the stage of cyanosis, and therefore they are picked up much later as Eisenmenger. So the age of presentation of Eisenmenger may be 8 years, 9 years, 11 years, 12 years. But yes, the process would have started earlier. If you were to catheterize them at 3 years or 4 years, they would perhaps been inoperable even then, although their saturation might have been 93, 94%.
It's a very informative, but due to paucity of time, I might have to interrupt because we have already 45 minutes. So
yes,
can we go ahead with a poll question number 3, and then we can go ahead with ma'am's talk. Can you have a poll question number 3, Monica?
Yes, ma'am. Question 3, right?
Yeah, poll question 3 and 4.
So I think it's visible on your screen. The question is, following cyanotic congenital heart disease is associated with LVA type of epics. So only single choice to be answered. Is it TOF with restrictive VSD, or DORB with restrictive VSD, TGA with restrictive VSD, or corrected transposition of great arteries with VSD PS? So you can start answering this question.
This was a bit tricky question.
Yeah, it's actually a difficult question also.
Yeah.
So we will give 5 seconds more to the students. They can have more time. Okay, so we have given about 60 seconds to the students. So we can stop the poll. Can I request Jyotsna madam to comment on this question? So it's a very divided opinion poll result. So in your opinion, what should be the correct answer, ma'am?
It's better to give an explanation and then tell what is the likely possibility. Because the tetralogy of the fallow, in that the VSD is usually the non-restrictive. That's why the communication between the right ventricle and the left ventricular pressures are almost equalizes. Once it becomes a restrictive, the problem comes is the blood flow from the right ventricle to the left ventricle that comes down. And already there is a obstruction to the pulmonary artery. So the major thing what is happening in the restrictive VSD in a tetralogy that follows, the 2 obstructions are there. One is at the VSD level, one is at the RV outflow tract, that is the PS. So the right ventricle becomes so diminutive that it is not able to sustain it. So this is the likely possibility. Yes, can happen. Yes, happen. But usually these are not the common conditions where we can have the left ventricular dominance in the top. Usually associated with an aortic stenosis or an AR or associated hypertension, we will get the left ventricular dominance. In the double ventricle, double outlet right ventricle, both the great arteries are taking origin from the right ventricle. Once already the left ventricle is underdeveloped because both great arteries are taking origin from the right ventricle. And now it is becoming restricted. So there is no blood flow, much of the blood flow from the right ventricle to the left ventricle. So once the VSD becomes restricted, left ventricle becomes much more diminutive. So it is not possible to have the left ventricular dominance. In the transposition of the great arteries with a restrictive VSD, in the transposition of the great arteries, usually with the large VSD is a biventricular dominance. Once it is the VSD becomes restrictive, then it becomes the left ventricular dominance. Corrected transposition of the great arteries with a VSD PS looks like a right ventricular dominance. So I think the transposition of the great arteries with the restrictive VSD should come as the first, and then the tetralogy with the restrictive VSD can be explained subsequently.
I have a slight different of variation. Is it okay if I tell, ma'am?
Yeah, please.
I think of all, if you ask a double outlet right ventricle with restrictive VSD comes as a first possibility, because the VSD is obligatory left to right shunt. In double outlet right ventricle, both the great vessels arise from the right ventricle. The left ventricle should empty into right ventricle, from there to aorta or pulmonary artery, both. Therefore, this is acting like a systemic ventricular obstruction. from the student's point of view, if you ask any cyanotic congenital heart disease with left ventricular obstruction, left ventricular apex apart from single ventricle tricuspid atresia, double outlet right ventricle with restrictive VST should be considered. Whereas the remaining various hypotheses are possible, but tetralogy fellow with restrictive VST, they behave like a serious right heart failure patients. Right heart failure is quite significant in the presence of restrictive VST. JVP will be increased and all. So corrected transposition, it's a bit difficult to tell whatever the form, the apex, because the right ventricle is going to be the systemic ventricle. That's why most of the times they will have mesocardia, anteriorly post ventricle. That's why it's very difficult. According to my view, I feel that DORV with restrictive VST acting like aortic stenosis will have LV apex.
Yeah, absolutely. I think the answer should be DORV with restrictive VSD, because the left ventricle, for it to be LV apex, either you have a diminutive right ventricle or the LV pressure is much more than what is the pressure on the systemic side. So tetralogy, if there is restriction, the RV pressure goes up and actually apex becomes RV. It almost behaves like pulmonary stenosis with intact ventricular septum. And we know that pulmonary stenosis with intact ventricular septum will have higher left parasternal heave, will have RV apex. Transposition and corrected transposition will not really produce left ventricular apex simply because the left ventricular pressure is not more. It is only the DORV where if there is VST which is restrictive, it is like severe aortic stenosis. And since it is like severe aortic stenosis, LV is going to be hypertrophic. So just all the students should remember that there are very few causes of cyanotic heart disease with LV apex. Tricuspid atresia is the conventional that we all know of. Single ventricle where you have DILV type of ventricle is the second one. And the third one is DORV with restrictive ventricular septal defect. These are the three causes of LVH in the ECG, LV dominance on examination. We can go to the next question, I suppose.
Yeah, thanks, ma'am. It was a very tricky question and we also got confused. So we can just go to the poll question number 4. And the question is, following physical sign is not a feature of Eisenmenger physiology. So first one is loud pulmonary component of second heart sound, or a grade 1 left parasternal heave, ejection systolic murmur grade 3/6, or a early diastolic murmur. So you will get only 15 seconds to answer this poll. We had this discussion also during the examination. So this will be okay. So I'm ending the poll.
So
yes, ma'am.
I mean, I can just say that although majority of the people have given the right answer, which is ESM or ejection systolic murmur grade 3 or more, but I think as Rupali said, we just discussed it that you can't have more left parasternal heave. Grade 1 is the way Eisenmenger physiology will behave, especially if it is VSD. So having a grade 1 heave is very much part of Eisenmenger. Having loud P2 is also very much part of Eisenmenger. And EDM, we all know PR can produce EDM. So the answer had to be ejection systolic murmur, because there is no reason for a systolic murmur of grade 3 to be present in Eisenmenger. The only systolic murmur that's going to come is from dilated pulmonary artery segment, which is not going to be more than grade 1 or 2, or it may not be there at all. So a loud systolic murmur is against the diagnosis of Eisenmenger syndrome.
Other panelists are agreeing. Can we go ahead with the...
I actually remembered Savitri Srivastava ma'am for this answer. She always emphasizes that any murmur more than grade 3 or grade 3/6, a long ejection systolic murmur rules out Eisenmenger syndrome. Her statement several times. It's a very, very, what Anita ma'am said is a classical teaching point.
Yeah. Okay.
Dosa ma'am, any further comment?
No, that's an obvious answer.
Okay. So, Dr. Nitin, you can continue with your examination, that echo and X-ray, another 5 minutes, and then we will go ahead with ma'am's talk. So can you show the ECG and X-ray and we can have discussion?
Yeah, I'm showing the ECG. This is a standard 12-lead ECG showing mark the right axis deviation of QRX, QRS axis being around plus 180 degrees. Patient is in sinus rhythm. And then also we can see the signs of right ventricular hypertrophy. But also you can notice one thing, that there is an early transition from V1 to V2.
So it fits with your diagnosis?
A little bit off track, that right axis deviation is much more marked than we would have expected.
Okay. But at least it tells you that it is likely to be VSD because you have an early transition.
Yes, probably large VSD.
Probably large VSD. Okay. So I think what you're saying is right. Generally, Eisenmenger will not have an axis of more than 135 or 150. This is a bit too much, too right. So we could probably think about a little more complex disease rather than a straightforward VSD. Okay. X-ray.
Suppose there is a left axis deviation. What is your comment?
If it was left axis, what would be your comment on the diagnosis?
Atrioventricular septal defects could be one possibility.
Yeah, one could be AVSD. Any other?
Or it could be some other, like we were discussing, other physiology like tricuspid atresia with.
Suppose if it is a VSD, left axis deviation, what kind of VSD?
Sir, as I said,
it is VSD by echocardiogram.
It's a large
What
VSD.
kind of VSD?
It could be a large muscular VSD.
Right. So it could be either an inlet kind of VSD of AV septal defect, or it could be a large muscular VSD that can modify the axis sometimes. Okay. Dr. Rao, anything else in mind?
Yeah, that's fine.
Okay. Go to the X-ray.
Because what I wanted to tell, if there is a VSD during infancy, somebody in periphery takes ECG, shows left axis deviation, the VSD will never be closed. So you have to send them for surgery. So any VSD with the left axis deviation, it's a dangerous VSD, just to emphasize the point.
But some of the muscular VSDs can also give rise to left axis deviation, and muscular VSDs do close.
Yes.
Okay.
This is X-ray chest PA view, situs solitus, levocardia, mild cardiomegaly I could see, and apex is little up, not too much, but little upturned we can say. And there is prominence of the pulmonary arc with the dilatation of the central pulmonary, main pulmonary artery, and left descending pulmonary artery and right descending pulmonary artery, with tailing of the right descending pulmonary artery is seen. We can also see some kind of pruning happening in the peripheral, in the periphery of the lung field, peripheral 1/3 of the lung field, and there is no prominent aortic knuckle.
So again, it kind of fits with your
no RA, and no RA in large.
No RA. Okay, all right. Okay. You have an echo. Quickly, maybe just show the echo so that we can finish off the case.
Okay. This is the first view showing situs solitus. This is the second view showing levocardia, and also an intact interatrial septum we can see. This is showing a apical 4-chamber view with showing atrioventricular concordance and a large VSD, large muscular VSD. This is same apical 4-chamber view showing with the color flow pattern, again suggesting flow across the interventricular septum, and no significant MR or TR. Then this is again 4-chamber view, so showing a large VSD with probably a bidirectional flow across the VSD, and more actually right to left. This is a short axis view at the level of great arteries showing a normal pulmonary wall with a dilated, hugely dilated main pulmonary artery. This is again a view at short axis view at great arteries showing with color flow interrogation of the pulmonary wall showing pulmonary regurgitation jet. This is the pulmonary jet measurement showing early diastolic velocity from where we can get the mean pulmonary artery pressure to be 82 millimeter Hg plus right atrial pressure. This is showing the late diastolic pressure of 48 millimeter Hg. By adding right atrial pressure, we can get the diastolic pulmonary artery pressure. This is the suprasternal view showing the arch of aorta. Some color distortion was seen, so we took a pressure gradient across this, but it was not showing any significance, so no evidence of coarctation. That's it.
So show us your final diagnosis, that slide which you had. Okay.
So
Madam, any other view which you wanted on echo or X-ray findings? Ma'am, you are muted. Just a minute.
Sorry. What is the question, Rupali?
Ma'am, any other view on echo which you wanted to have for this, or any other finding on echocardiography?
So basically,
ma'am is not able to. Yes.
Yeah,
And we can go ahead with the discussion.
Yeah, that's okay. I think a short axis would have also shown the muscular VSD. Short axis view of the at the level of ventricle would have also shown the VSD. Otherwise, I think the diagnosis is quite obvious, large VSD. And Nitin, should you have done a contrast echo just to be very sure?
We could have done to show that that predominantly it is a right to left or left to right.
No, but did you really need to do it? I mean, you can always do things, but point is it going to be of any use or additional value? That's the question.
For operability, maybe
in somebody who is obviously blue, you are still thinking about operability.
Already, ma'am, she's blue.
So somebody who is already blue, what is the point of doing a contrast echo? A contrast echo is done in those cases where there's no obvious cyanosis or very minimal cyanosis, and you just want to see, like borderline cases or something. Here, the patient saturation is only 80%. At 80%, you don't expect her to be operable by any stretch of imagination.
Okay.
Sorry, Dr. Rao, you were saying something. Dr. Rao, you wanted to say something?
You're muted. No. Sir, you're muted.
Whatever you told, the clinical obvious cyanosis, the clubbing, saturation is lesser than 85%, doesn't need any kind of contrast echo. If the saturation is borderline, then you have to do exercise saturation. You make them to walk and then do saturation, or you do bubble contrast. Otherwise, by and large, not required. Dr. Nitin, I just want to ask you a question.
Yes, sir.
This patient had heart failure during infancy. What were the mechanisms of heart failure that time? Now you are telling there is no heart failure. Patient eventually may succumb due to various complications, which includes heart failure. What will be the mechanisms of heart failure in future? So this patient will have heart failure in future, had heart failure in the past. What was the past heart failure mechanism? What is the future heart failure mechanism?
Yes, sir. So in infancy, because the shunt was predominantly left to right, so there was a volume overload situation of the left sided chambers, which led to increased LVEDP and later leading to heart failure symptoms. However, with progressive increase of pulmonary hypertension, if the patient going into pulmonary hypertension, the shunt, left to right shunt actually vanished. So currently now what has happened is that now the patient is in a PH situation. So right ventricle is now in under kind of a pressure load situation. So over the time, we expect that this right ventricular failure patient will develop right ventricular failure over the time.
So you had heart failure due to preload, then increased EDP, capillary wedge pressure, volume overload situation. So a flow dependent heart failure in the past. Now a afterload related heart failure to the right ventricle and hypoxia induced cardiomyopathy to both ventricles are possible in Eisenmenger syndrome. So two different mechanisms of heart failure you are going to see in one patient. Modified, but a good answer. You attempted good answer.
Thank you.
Thank you, sir. I think it was very informative and very educated points for the case with cyanotic coronary heart disease with Eisenmenger. We want to discuss on a more length and to learn from your wisdom, but due to paucity of time, we have already crossed 15 minutes from our target time. So if you allow, can we close the case examination and go ahead with the lecture part?
Thank you very much. Fine.
Thank you. Thank you.
So I would request Anita Saxena, madam, to go ahead with the talk of today's session, approach to a case of cyanotic congenital heart disease, and give her opinion and give her wisdom on this topic.
Nitin,
Can you
you
stop sharing the screen?
Yeah, so that I can start sharing.
Yeah, thank you, Nitin.
Okay, great. So I'm glad that we have covered many points, and that will really help me to sort of quickly go through. Just emphasize some points that I will. Let me see if I can. Yeah. Okay. So cyanosis can present at any age, and we saw one adult today. But remember, some of the most complex heart diseases are likely to present much earlier. And we did discuss that natural survival is such that only tetralogies, Eisenmengers, etc., survive to adulthood. Most of the very complex heart disease don't even get there unless they are intervened. History, you already talked about the cyanosis. There was no cyanosis in the beginning, but there was history of failure. Very, very important to elicit. Even in an adult, you may have difficulty in eliciting because the parents may not be available. But if they are, like in this particular case, then it will be important to know whether there was heart failure in infancy or not. When it comes to cyanosis, I think we did discuss that very early onset cyanosis is seen in these conditions, which is transposition, pulmonary atresia, intact septum, pulmonary atresia, VSD, TAPVC of obstructive variety, tricuspid atresia, abstinence anomaly, and a late onset would indicate Eisenmenger syndrome, like the patient we discussed. And yes, we did think about TAPVC abstinence anomaly also in that situation. Remember, tetralogies are usually not cyanosed at birth. They tend to develop cyanosis after a few weeks or months of life, but most often the history will be early childhood, maybe infancy, especially if you're getting an adult with tetralogy of Fallows. On examination, again, whether patient is syndromic or not is very important. And again, even at this stage, you have to look for features of heart failure. May not be present in adults, but are likely to be present in infants and small children. And of course, look for thrills, sounds, murmurs. Always examine on the back and the front. And second heart sound is very, very important, as we've always been talking about. And we did discuss the importance of second heart sound in differentiating the level of Eisenmenger syndrome. Hemodynamically, this is the classification. We all know: increased pulmonary blood flow, reduced pulmonary blood flow, then pulmonary venous hypertension. But what is important to understand is that different congenital heart disease will have different pattern depending on the age of the child. So with tetralogy, one can see a patient at any age, including adults. When it comes to condition like transposition of great arteries, very, very early presentation, hardly ever survival. Let's say 80% do not survive beyond 1 year if they're not treated in time. Then the second reduced pulmonary blood flow situation, which often occurs later, is Eisenmenger syndrome. And as we discussed, this is also decreased pulmonary blood flow situation. Very rarely you may have conditions like obstructed TAPVC, hypoplastic left heart, and these are most sick babies. They would present very early in life. PDA is not the case. PDA does not help them much, and therefore the likelihood of presentation is going to be very early. And then, of course, Epstein can present at any age. In fact, it may have bimodal distribution. Very easy to differentiate if you have an X-ray at hand, and I would always recommend, before going for an echocardiography, please do an X-ray, especially if you're not sure if you're dealing with a tetralogy situation or an increased flow situation or even Eisenmenger situation. Rarely you may have a condition with severe pulmonary venous hypertension. Obstructive TAPVC classically presents in this manner. And again, these babies present much earlier in life. But let us talk about cyanotic heart disease according to the time or according to the mode of presentation, because when they come to you, they may present to you with cyanosis and heart failure, or they may present you with just cyanosis without heart failure. So when it comes to heart failure with cyanosis, it's exactly the same list comes which we talked about in increased pulmonary blood flow situation, some of which we discussed: truncus arteriosus, single ventricle, transposition, TAPVC, and so on. But when a patient presents only with cyanosis without features of heart failure, then it is going to be tetralogy or tetralogy-like conditions. But yes, Eisenmenger is also going to fall into that category. Sometimes they are just presenting with murmur. They may be pink, they may look pink, they may be very minimally blue, typically pink tetralogy. And these are the other ways in which they can present. But what is important whenever you see a cyanotic patient is to look at the age of the patient and if there are any syndromes, because that is going to give you a clue as to which group are we dealing with. So let's talk of neonate and infants. And we know that in neonate and infants, patients can present with heart failure like transposition. Patient can belong to tetralogy group, but sometimes they come in a very collapsed kind of a state, and that is because of the ductus dependent critical congenital heart disease. And these are usually 3 days old, 4 days old baby who has gone home very well and comes back with a cardiovascular collapse kind of a situation. So you have to obviously think about a ductus dependent condition in these patients. The second, which is older children, and when we talk of 3-year, 4-year, 5-year-old, then the whole list of increased pulmonary blood flow is almost gone, as you can see here. Transposition, truncus, these patients would not survive to this age, or even if they survive, they will not present in heart failure, because by this age, they would have developed Eisenmenger syndrome. So in those presenting with cyanosis, the classical example is tetralogy, but Eisenmenger syndrome gets added when you see older children and adults. So these are the two common conditions, and as we discussed in the question, tetralogy in our country at least remains the commonest cyanotic congenital heart disease in adults. The second part that you have to look for is look if there is a syndrome. For example, if you have a Down syndrome child, think about AV septal defect. Even if you have a tetralogy looking baby but has Down syndrome, it could be AVSD with pulmonary stenosis rather than simple VSD pulmonary stenosis. So again, looking at the child, especially this DiGeorge syndrome as we call it, it tends to have a lot of outflow tract anomalies like tetralogy, double outlet, and so on. And these babies look quite normal actually. So you have to be really on the lookout if there is an evidence of DiGeorge syndrome or not. And of course, you can always get chromosomal anomalies. For those patients who are presenting little later in life and have cyanotic congenital heart disease, how do you decide which one are we dealing with? So some of these points we discussed. For example, if there's a prominent A wave in JVP, even tetralogy patients in adulthood can show you prominent A wave because of RV being very stiff in them. LV apex, we already discussed, tricuspid atresia, univentricular, single ventricle, and DORV with restrictive VSD. Second space pulsations, corrected transposition, single ventricle because of L post aorta. Of course, Eisenmenger can also give you pulsations in the second space. And if you have a more than grade 1 left parasternal heave, think about ASD with PS. That means severe PS with intact ventricular septum or restrictive ventricular septal defect. If in addition to ejection systolic murmur of PS, you're also hearing a pansystolic murmur near the apex, think about these conditions because AV septal defect and CCTJ may be associated with AV valve abnormalities. Early diastolic murmurs are quite unusual. If they appear, then it could be truncus arteriosus. Even Eisenmenger can give you EDM, but that's because of pulmonary regurgitation. Seesaw murmur, systolic, diastolic, both is absent pulmonary valve. If there is slow heart rate in somebody and it looks like tetralogy, think about corrected transposition of great arteries with VSD-PS. And if there is murmur which is much more than the degree of cyanosis, because we generally say in tetralogy there is a relationship, inverse relationship between the degree of cyanosis and the loudness of the murmur. But if that relationship is lost, then think about conditions like transposition or admixture lesion with VSD and PS. So tetralogy, just briefly, most common congenital heart disease, as we said, especially in adults, and you can have similar condition or similar situation in many other conditions called TOF physiology, and this is the list which many examiners are quite fond of asking. But basic thing is that all of them have a large VSD and all of them have severe pulmonary stenosis. So these children usually will give you good history of normal growth and weight gain, no history of heart failure during infancy, and systolic thrill or dejection systolic murmur, which is the hallmark of pulmonary stenosis. ECG can give you a reasonable clue. You have right axis deviation with right ventricular hypertrophy in early transition, suggestive of tetralogy. You may have LAD and LVH, which is classical of tricuspid atresia, or you can have a condition if you have so much of RVH, that means severe right ventricular hypertrophy with strain. Please don't make a diagnosis of tetralogy. This is a patient who has virtually intact ventricular septum. Either the VSD has become restrictive or is not there. Again, as I told you, if the heart rate is 70, especially in a child, and you find complete AV dissociation, you are perhaps dealing with corrected transposition of great arteries with PST PS. X-ray, yes, it can help you, because in tetralogy situation, you can have a typical boot-shaped heart, which is because of pulmonary bay and a right-sided aortic arch and oligemia of the lungs. But you can have X-ray quite typical of tricuspid atresia, single ventricle, or situs solitus with levocardia, which is quite classical of corrective transposition. Whenever there's a mismatch between situs of the viscera and situs of the heart, think about corrective transposition. But what is common in these X-rays is that there is no cardiomegaly and there are black lung fields. So you may not always have typical X-rays, but this is what will always be there: no cardiomegaly and lungs being oligemic. So I just show you this case, 28-year-old male, cynosed, now becoming class 3, no history of squatting or heart failure in the infancy. And these are the possibilities. We discussed most of it. He's got ejection systolic murmur, which is grade 3/6. Once you have that murmur, please think about tetralogy or tetralogy physiology. Eisenmenger should not be made the differential diagnosis because of the loud systolic murmur, and Epstein's anomaly is not likely because patient has single second heart sound. So it's pretty easy to make a diagnosis of tetralogy or tetralogy-like condition at the bedside, and you should never confuse tetralogy with Eisenmenger syndrome at the bedside. So how do we differentiate the two, especially when it comes to your exam? You get a cyanotic adult and you can think of these two possibilities. See, tetralogy is also reduced pulmonary blood flow, and Eisenmenger is also reduced pulmonary blood flow. The only difference is that pulmonary artery pressures are severely elevated and pulmonary vascular resistance is severely elevated in Eisenmenger, unlike tetralogy of Fallows. So Eisenmenger, we all know, develops secondary to a large left to right shunt, could most often VSD or PDA, and we saw one patient of VSD today. But I think what is important is that there is no cardiomegaly, there is no heart failure, and there is minimal left parasternal lift, and that is what makes it very similar to tetralogy of Fallows. So how do we differentiate? If you have a history, then you might get history of failure to thrive, heart failure in infancy, if you have that history, which is going to be not there in tetralogy. And then ejection systolic murmur. Remember, click is going to be there in both, because it will be aortic click in tetralogy and pulmonary click in Eisenmenger, but it is the murmur, and we did discuss that any murmur which is more than grade 2 should never be thought of as Eisenmenger. It has to be tetralogy or tetralogy physiology. And this also we discussed that to decide where is the level of shunt, we depend primarily on second heart sound. This is what the Paul Wood series has taught us for ages now. And of course, if you are lucky, if you have differential cyanosis, then also you can make a diagnosis of PDA. Cardiomegaly is a hallmark of ASD only. But please, do not ever make a diagnosis of Eisenmenger syndrome in anybody who is less than 2 years of age. If you are suspecting it, then you must catheterize and be very sure that this patient is inoperable. Eisenmenger syndrome is to be differentiated from pulmonary artery hypertension, which can be hyperkinetic in small children. So pulmonary artery hypertension can be hyperkinetic and obstructive. In small babies, in infants, it is hyperkinetic, but over a period of time, it becomes obstructive when the PVR rises, and then only we call them Eisenmenger syndrome. This is just a couple of slides for a small baby who presents with failure and deep cyanosis to the emergency room. And here we have to keep these conditions in mind, which some of the pediatric fellows who are attending this class will be seeing in their emergency. What is the hallmark is that they would present in early infancy with heart failure and cyanosis. Very few of them are going to make it to the adult life. So very early presentation with heart failure, absence of murmurs, very soft murmurs. If you hear very carefully, you might hear even flow murmurs. But what you should be always worried about, if you have an infant or a baby who has no murmur and is blue. This baby is going to be much sicker than a baby who has a murmur, because the one who has a murmur is going to be tetralogy. The one who doesn't have a murmur is going to be transposition of great arteries. X-ray, if you're lucky, you may have typical agon-side appearance, which takes a little while to develop. It may be present in a 1 month or 2 month, but don't expect it in a neonate. Sometimes you have this typical figure of 8 appearance, which also happens usually beyond 9 months to 1 year of life. So if you have these X-rays, I think you can make a diagnosis. Or if you have an X-ray with no cardiomegaly and ground glass appearance of the lungs, which is typically seen in obstructive TAPVC, and these babies are obviously very, very sick. So this is probably the last case. I think we've discussed at length. This is 15-year-old, reasonably asymptomatic, may complain of palpitation, white fixed second heart sound, very short murmur, quiet heart, cardiomegaly. This is called box-shaped heart and very classical of Epstein's, where you have no RVH, but you have wide QRS or RBPB pattern. So this is obviously, but if you have a cyanotic patient or adult with widespread second heart sound, Epstein is not the only diagnosis. Do think about ASD Eisenmenger. Do think about very large ASD even without Eisenmenger, total anomalous pulmonary venous connection. So just remember the list of conditions which can produce cyanosis with a widespread second heart sound. Otherwise, classically, tetralogy as well as Epstein's have single second heart sound. Of course, this is the final diagnostic test, but remember, you are going to be very accurate in echocardiography if you are supplementing your information with the clinical data. So don't bypass X-ray ECG clinical examination and go straight for echo. You are probably going to make much more mistakes if you straight away go for echo. Try to make a clinical diagnosis, at least a group, which group it patient belongs to, and then go for echocardiography. I can tell you an example of, I think, about 17, 18-year-old boy who came to us with Eisenmenger syndrome. And when you look at the echo, it looked like Eisenmenger syndrome, but actually the patient had DCRV because the obstruction was very low down and it was an adult, so it was missed. But what gave us the clue was that this patient had grade 3 over 6 systolic murmur. So how can you have a systolic murmur in Eisenmenger syndrome? And that made a difference of life and death for that patient, because now we know that patient can be operated and can be dealt with reasonably well. Whereas if you label somebody as Eisenmenger syndrome, then you will just not do anything about such patients. So clinical examination should never be bypassed. So this is the summary slide. Go for the age. What is the age of the child? If the baby is a neonate or is a small infant, if there is heart failure or not, and if you can look at this algorithm, age and presence or absence of heart failure, then you will be reasonably certain in making a diagnosis, at least a group of, if not necessarily exact diagnosis, but at least close to the diagnosis. If there is heart failure, again, think of large flow situations in a neonate and infant. These children are sick. They may not have murmurs, but they will be having significant heart failure. If there is no heart failure, think about tetralogy even in an infant who is blue but not in heart failure. Older children, again here tetralogy is going to be quite common. Older children, heart failure is very uncommon. If it is present, you have to think of some ventricular dysfunction and causes of heart failure in tetralogy, which I'm sure all of you know. But if there is no heart failure, again, tetralogy becomes the commonest lesion or tetralogy physiology. When it comes to 10-year, 12-year in adults, again, heart failure uncommon, but can happen late onset in 30s and 40s because of ventricular dysfunction, sometimes because of large aortopulmonary collaterals or any other complications that you know of. But if there is no heart failure, again, tetralogy becomes the common lesion. And even in this age group, tetralogy and Eisenmenger would remain the common lesions compared to any other condition. So this is the algorithm. If you can follow, then I'm sure you don't have to worry too much about the diagnosis. If you have a sort of a idea as to which group this patient is belonging, I think you can further do the X-ray ECG and get the diagnosis. Thank you very much, Rupali. I'll stop here.
Thank you, ma'am. Thanks a lot. It's a very vast topic and there are so many things to be told, but you have given clear directions and clues to the most important findings and to management also. Thanks a lot for making a concise presentation of a huge topic. I thank Dr. Anita ma'am, Dr. Nageshwar Rao sir and Dr. Jyotsna ma'am for being here and sharing their wisdom with us. It was a very interesting case discussion and very informative talk. Thank you all. Sorry, we have overshoot our time by almost 20 to 25 minutes. But unless this discussion happens, we cannot have a clear picture of what we were planning to do today. So thank you all. Thank you, everyone.
Thank you.
Sir, Jyotsna ma'am, Nageshwar Rao sir, any concluding comments?
I think one of the best cyanotic heart disease topic, what ma'am described from neonate to adulthood with X-rays, very, very informative. Thank you, ma'am. Very nice.
Thank you.
Even I should thank Madam's presentation. The last question which you are not posted, I would have been answered differently than Madam now said that take an X-ray. So I wouldn't have been thought of that taking the X-ray is going to be the more urgent than doing the echocardiography. So the Madam highlighted the very much on that. I'm thankful to you, Madam.
Thank you.
Thank you, ma'am. I think the best part was the clinical examination. Like there was an article, the stethoscope is out of fashion, but I think the stethoscope will remain, and especially with congenital heart disease, because we cannot just be dependent on the echocardiography. So I would like to thank the Jyotsna ma'am, Nageshwar Rao sir, Anita madam for giving their valuable time and valuable comments. And Hema, you can just conclude the session and we can close this part.
Yeah, like Dr. Usha and Dr. Rupali have said, thank you very much for an excellent discussion. The stethoscope will stay, and as when we learned echo, this was the teaching: do your ECG, do your X-ray echo, and see the patient auscultate before all that, and then do your echo. And thank you, ma'am, for highlighting these things. I'm sure our PGs will benefit from all the teachings today. And thank you, everyone, for a wonderful discussion.
I would also just like to thank the students, or rather Nitin, who has presented the case. I think he's done a good job. But I mean, Dr. Jyotsna and Dr. Rao and others can also comment. But just I think it takes a little bit of guts to present a case, and they're all adult cardiologists. They're not pediatric cardiologists. So I think they've done a good. He has done a good job.
Thank you.
Yeah, we apologize, ma'am. They were that really Dr. Nitin presented very well. Like many points which he discussed and answered it, like we were also a little might stumble on that. So, Dr. Nitin, you presented very well. You were the star of the show, I think I would say.
Thanks so much.
So,
thank you.
Thank you, ma'am, for joining. So we conclude our third e-class session and hoping to see you soon in the next month e-class
For all the
sessions by
attendees,
Wincars.
the recording of the session will be available on the Wincars website in a few days' time. So if you have missed any points during the presentation, you can go through the recording again. Thank you. Thank you all.